Thank you. Good morning. Today we'll discuss some important topic in orthopedics, infections of bones, and maybe in the subsequent classes about the joints. As most of you know, infection is a very dreaded complication, especially in orthopedics. Especially when you operate on a bone, infection is the worst thing that can occur to you as a surgeon and for the patient as well. So the traditional teaching in orthopedics is you can spit into the abdomen, but you should not breathe into the joint. So it is so sacred in a way, or abdomen can take care of itself. Even if you spit into the abdomen because of its large peritoneal reflections can take care of itself. But a bone cannot take care of itself, with the result that a mild infection somewhere in the body can also be reflected as an infection of the bone, which we'll see, and will lead to debilitating complications throughout the day. It's said that infection of a bone is like getting married. So, if somebody asks you after your marriage, are you married? If you want to admit or otherwise, you have to say, yes, I am married. Your marriage may be on the rocks or you are happily married. Similarly, once a bone gets infected, it stays infected. It doesn't mean that it is obvious that infection is seen outside. No. With the body's innate immunity, you can control it to the maximum extent, but some semblance or some organisms will be lurking around somewhere deep in the recesses of the bone somewhere, and as and when your body defenses come down, then definitely they will make a comeback, and that comeback will be with vengeance. So this is one of the things we dread. As an orthopedic surgeon, if I operate on a patient, I will take utmost care before operation, during operation also. That's why in the first year of our post-graduation, our professors asked us to clean the area. So we used to do this cleaning 3 to 4 days prior to the surgery. At that time, it was like, I used to think that this is a useless job, which I have never done, but we had to do it. So all the operating areas like the limbs, they appear to be very clean compared with the rest of the body, because the patient will be bedridden, he is not taking bath for so many days, so naturally he will be a bit dirty. But the part which is to be operated used to be like very clean, because we used to clean it with shampoo morning, evening, some akin to these cattle being cleaned in village tanks and all. So we take utmost care, but you know, this is a multifactorial. Even if the surgeon is very careful, somebody from his team or something if goes wrong, then it will lead to infection. So let us see some terms, what are the various types of infection which can occur in a bone, and how to diagnose it and how to manage it. Bone infection, usually it's called osteomyelitis. Osteomyelitis is infection of the bone, and usually whenever you say osteomyelitis, it is taken for granted that it's only a pyogenic organism. That means osteomyelitis, you visualize that there is an infection of the bone where there is aggregation of the pus. You can see here, it's a diagram from the textbook Adams. Here you see a bone, I think by the looks of it, it looks like lower end of the femur, and this green thing all around in the joint is the pus. So we expect something similar whenever somebody says osteomyelitis. So osteomyelitis is nothing but infection of the bone, mostly by pyogenic organisms. All of you know what are the bacteria which are commonly infecting the bone. We'll see. Coming to types of osteomyelitis, specific and non-specific. Non-specific, you have so many like Staphylococcus aureus. Staphylococcus aureus is the commonest cause of osteomyelitis. So this is an entrance bit. If you come across that, I think you can thank me while ticking it. So Staph aureus is the commonest organism, and other things can cause infection of the bone like streptococci. We'll enumerate them as we go along. Then specific means there are some infections which are which can occur and they have some changes in the bones, typical of them. So whenever you say specific osteomyelitis, you think of tuberculosis. Tuberculosis is one of the commonest infections of the bone and the joints and the spine, and it can mimic anything. Previously, when we were medical student, the syphilis used to take that place. Syphilis can mimic any disease. So whenever you are examining a patient about uncommon diseases, then you need to keep syphilis and tuberculosis in mind. Could this be syphilis or could this be tuberculosis? But syphilis is on the downtrend now because so many other infections are in the forefront. So syphilis is on the downward spiral, and tuberculosis unfortunately is still rampant. So the specific infections, you should think of tuberculosis. Sometimes maybe there is something, a specific entity called typhoid osteomyelitis. All of you know typhoid infection is caused by a specific organism, and this typhoid usually a GIT problem, Peyer's patches, usually if I am right. So it can infect bones and it will lead to osteomyelitis. Typical osteomyelitis, typhoid osteomyelitis, more common in thalassemia patients. I think this is all my entrance knowledge. Please verify and tell me if I am wrong. Right. Even fungal infection is known in of the bones. So there will be fungal actinomycosis or maduromycosis. All of you know that there is an entity called maduromycosis, Madura foot. So due to which there will be a lot of sulfur granules coming out and limb becomes black. So we'll discuss those things when we come to it. Okay, so fungal infections of the bone also known, and then some parasites like hydatid cyst. Hydatid cyst, Echinococcus granulosus, I think it's a dog tapeworm. So it can even infect brain. Can you believe that? Yeah, hydatid cyst. So you should this usually more common in non-vegetarians. When we were students, we used to get more common in non-vegetarians, but of late it is occurring even in vegetarians because the water which is used to raise those crops is infected. So once that occurs, I think even vegetarians get this, and hydatid disease of the brain occurred in one of the famous tennis stars of India, and he had seizures and all, and I think it's Leander Paes, and he had to be treated for that. So it's very rare, but it can occur. Hydatid cyst of the bone is a known clinical entity. So apart from bacteria, even fungal infections and parasitic infections of the bone are known, apart from the specific types of osteomyelitis. Coming to the clinical type of osteomyelitis, so those are all the organisms. Now coming to the clinical typings, so clinical classification would be acute osteomyelitis. Whenever it occurs in the initial phase is known as acute osteomyelitis, and if it is there with us for some time, like our COVID, now it is in the chronic phase. Now we are not too much worried about it, and we are not maintaining that social distance, and we are not using those masks which we should. With the result, what is happening is more and more number of infections are coming day by day. More and more cases are coming, and in fact, the situation in the national capital is very grim. It was like in Hyderabad, just say 2 months ago, when no hospital beds are available. Even in Delhi now, it is happening. So you should be very careful. Don't think that we are past that stage. Unfortunately, no. And the incidence is still high. And if you are not careful, not wearing the mask or not maintaining the physical distance and not washing your hands and all, so definitely it will spread. You will become the major spreaders. So your score should be as low as possible. Don't get infected and don't infect. That should be your mantra. So if you feel ashamed of yourself if you get infected, and you feel doubly ashamed if you go on spreading it. So that is about acute osteomyelitis and chronic osteomyelitis, and there is no some other clinical entity which fits somewhere in between subacute osteomyelitis, and there is a acute flare-up of chronic osteomyelitis also known. So a patient with acute symptoms who is already diagnosed as having a chronic osteomyelitis. As I told you, the infection which is lurking in the deep recess somewhere in the body once again becomes active because of our decreased immunity. So this is a lifelong association, so we should be very, very careful. So acute osteomyelitis can flare up even in a relatively subdued chronic osteomyelitic patient. So you should always remember this possibility in these patients. We'll discuss something about acute osteomyelitis, what otherwise known as acute primary osteomyelitis. So here, let us throw some light on the anatomy of the bone. All of you know that there is a epiphysis and there is a metaphysis, and there is a epiphyseal line which separates epiphysis and metaphysis. All of you know that epiphysis is the growing end. There is a growth plate where the growth occurs in the longitudinal increase in the length of the bone usually occurs because of the activity of the growth plate. So here you see in this diagram, the epiphysis end of the bone is covered by articular cartilage. All of you know that is a specialized tissue which lines the ends of the bone. So this is the epiphyseal line of the growth plate, and this is a nutrient artery. All of you can see this is a touch, very, very sensitive to the touch. The moment I touch it, it's changing. So all of you can see the diagram and see the nutrient artery entering from the middle and going towards the epiphysis. It has its branches, and even periosteum is supplying the bone through periosteal artery. So all of you know periosteum is the outer covering, and this bone has a spongy cancellous bone and a compact bone, the cortex. All of you know. So these are some of the headings. The bone is marked there, and the problem here is the artery, nutrient artery, becomes a U-shaped, turns on itself, and there are a lot of hairpin bends in the metaphysis. So they stop short of the epiphyseal line, or they usually don't pierce. That's why infection may not go into the epiphysis. So it's limited to the metaphysis and very, very common. The blood flow, though more, but becomes sluggish because of the hair loops there. So the commonest seat of infection will be metaphysis. So this is also an entrance bit. Why metaphysis? Because there will be U-turn. There are the arterioles which are there. They are tortuous vessels. That's why the flow of blood, the velocity is very, very low. That's why whenever there is a decreased velocity, there is a tendency of things to settle down. If the pace of life becomes very slow, as of now, we have a tendency to settle down on the chairs, watching Netflix and Amazon Prime. In the bargain, putting on some unneeded, unwanted weight. Okay, so even here the similar thing happens because of the tortuosity and because of the lesser pace of blood flow, the organisms settle. So unwanted things also are settling down even in the bone, as with all of us. So this is a schematic diagram where you can see the arterioles and the epiphysis on the top and metaphysis, diaphysis, periosteum, cortex, central vein and artery you can see, and in the medulla then the tortuous arterioles you can see, and here the another cause for metaphysis is because of the tortuosity, relative avascularity. This is something like if you are traveling in the sea and your fresh water supply is gone, so you are in the high seas, all around you have a lot of water, but you have very less amount of water. That water is not available for drinking. You can akin to that. So a lot of blood flowing around, but unfortunately it is relatively avascular, so the bacteria can thrive there. And as we have seen, the epiphyseal plate is supplied with blood by a separate artery. So there is a clear zone of distinction between these two, metaphysis and epiphysis. So usually the infection will not jump from metaphysis to epiphysis. So it is located in the metaphysis. And what happens to the infection from metaphysis? Let us see. Usual source of infection is hematogenous. That means there is bacteremia, bacteria in the blood, maybe from some distant focus somewhere in the body, maybe some dental infection or some abrasion or a soft tissue infection somewhere in the body. Then the bacteria get into the blood, and that blood may come into the bone, and those bacteria finding this metaphysis as very convenient, they may settle down here, and that is the commonest root of acute osteomyelitis. So hematogenous is the commonest type. So here you can see they are coming through the blood and settling down here. So this is the growth plate and this is the epiphysis. So hematogenous. And as we have already seen, Staph aureus. Staph aureus is the commonest organism. All of you know that Staphylococcus, usually there are two aureus and albus. There are two organisms which are clinically relevant usually for us now. And all of you know that aureus means aureus. Most of the girls are very much interested in that. And recently there was one occasion, Dhanteras. So usually a lot of hype and hoopla about unless you buy gold, it will not be safe for your husband. So that is a very good ploy, you know. Once you come and say that it's very for your safety only I am buying, then that poor guy cannot say anything, and he goes out of his way to buy gold to the wife. So aureus means gold. Because why it is named aureus? It's not that Staphylococcus is also interested in gold like most of you. No, it's not. The colonies of this particular organism, they are golden yellow in color. And there is one more organism, that is albus. That means the colony is white. So the golden yellow colonies of Staphylococcus aureus, because of that the name was given. And this is the commonest organism which causes acute osteomyelitis. And coming to the kids, because of this lower immunity, you find even other organisms causing this infection. That is, a streptococcus also can cause, and pneumococci. Usually they have their departments are different. But if the conditions are favorable, that means there is no opposition as it is, then definitely any organism can cause this infection. So streptococcus and pneumococci are also common organisms in kids. and common sites are ends of the bones. Why ends of the long bones? Because the growing activity is very high in these. Either it can be either upper end or lower end, and usual bones are lower end femur and upper end tibia. They are the most of the times they are the fall guys, because most of the growth activity occurs at these ends. So lower end femur or upper end tibia. Usually, if you don't know anything, the commonest location or where it occurs, either infection or tumors, you can get away by writing lower end femur and upper end tibia, because the vascularity is more. That's why more chance of seeding either infection or tumor also occurring in these areas is very high. So commonest sites are ends of long bones. So that infection has occurred, initial infection has occurred. This is a schematic diagram taken from a textbook, of course. So this is the metaphysis where the initial infection is there. Then what are the routes it can take? So the one common route is it can extend in the medullary cavity, like here. It can go down and infect the whole bone. That is A. And B, it can injure and this bone becomes porous. Once the severe infection is there, bone becomes destroyed. This cortex comes out of the cortex and stretches the periosteum and swells there. So it will be a subperiosteal abscess. It can be a subperiosteal abscess. Or if it is severe, then it can breach the periosteum also. Once it breaches the periosteum, then it can come out of the bone into the soft tissues, and it will be an abscess in the muscular. So acute osteomyelitis can lead to septic arthritis also. It can go down the medullary cavity, it can form a subperiosteal abscess, or it can form an abscess in the planes of the muscles, or it can lead to septic arthritis. So, if a patient comes to casualty with acute osteomyelitis is a very febrile condition, and the pain is very severe. That pain, because already the infection is in the medullary cavity and it has come out and staying beneath the periosteum. So it stretches the periosteum, and inside the bone the nerve fibers may not be there, but periosteum is richly supplied, and once you stretch the periosteum, the pain becomes very unbearable. And as you know that infection, the signs of inflammation will definitely be there. So usually common in a child, maybe after an injury or maybe after some other infective focus somewhere in the body, or sometimes even a minor injury somewhere can lead to, after some days, will lead to acute osteomyelitis. Here, as I told you, it is a high swinging temperature. Temperature is very high, maybe around 101, 2, and severe pain. Patient will not allow you to touch. The moment he sees you, he starts crying. And there may be diffuse swelling and warmth and tenderness. All these inflammatory signs are there, and patient will not move the limb because of the severe pain. And you may think that maybe this is a neurological condition and patient is unable to move because of the paralysis. That's why this is called a pseudo paralysis. So most of us are pseudo intelligent or pseudo genius, but here this is pseudo paralysis because of the severe pain. So never ever lightly touch the patient. Don't take it very seriously, because patient will not take you into confidence if you are very if you are very rude to him, if you are not careful to him, and if you go on touching or to find out how tender is it or which bone is involved, he will not accept it. As it is a child, he will be crying, and the moment you start doing any of these things, then he will start crying along with him. His parents may also cry, and patient may go to some other doctor, and then you may have to cry. So don't do that. Be very careful, be very gentle in the examination. Here, if you are allowed, then if you can palpate, you can feel a fluctuant abscess. All of you know what a fluctuant, how to know whether it is fluctuant or not. Then if it is a knee, then it is swollen. Sometimes even without infection, knee becomes inflamed. There may be a sympathetic effusion into the joint. Once you take out the fluid and send it for culture, you may not have any bacteria. This is sometimes it may be a sterile. It's a something like a sympathetic. Somewhere there is a problem, some inflammation in and around, and then definitely there will be some seepage into the knee joint, which will sympathetic effusion. But in septic arthritis, it will be very, very severe. So that is the difference between sympathetic effusion due to osteomyelitis, and if it breaks it into the joint, and septic arthritis is very, very painful. Okay, if you take aspirate, you will get frank pus in septic arthritis, and you may get some fluid, sterile synovial fluid in acute osteomyelitis. That doesn't mean that there is no infection. So if you want to get the bacteria in acute osteomyelitis, no need. If you take the synovial fluid, it is of no use unless it is a septic arthritis. So you need to get from the bone. How do you do it? We will see. So this is an important difference between septic arthritis and acute osteomyelitis. And general and systemic examination has to be carried out to know the primary source of infection. Coming to the investigations, blood investigations, routine blood investigations need to be done, where white cell count, especially polymorphonuclear sites, are more because of the purulent infection if it is there. Okay, then ESR is raised. You don't usually bother about ESR, or nowadays what is in vogue is CRP. CRP is more relevant than ESR. And culture, that's the most important thing. You need to do positive blood culture. If you are not getting positive blood culture, maybe you need to aspirate and send the aspirate for culture and sensitivity. That would be most useful rather than blood culture. But usually, because hematogenous is more common, you can get bacteremia and get positive blood culture. Coming to the other investigations which we have, X-rays. But in acute osteomyelitis, the radiological change comes after late, say around after 1 week. So you should not wait till radiological changes, because you will be losing a lot of time. So you are making the acute osteomyelitis turn into chronic osteomyelitis. So the clinical examination and the blood investigations will definitely tell you that it is osteomyelitis. You need not wait for radiological signs. But even in X-rays, initially you can find some changes, or in MRI you can see acute osteomyelitis also. But after say 10 days or 2 weeks, definitely the infective changes in the bones are clearly visible. So the earliest sign is rarefaction in the metaphysis. So that means the metaphysis, which is the seat of infection, becomes rarefied. That means it is not as bright in the X-ray as the other parts of the bone. So that becomes a bit dull, a bit black on X-ray. So rarefaction, and normal architecture of the bone is getting lost, because there is infection and a collection of fluid there. So it's not normal. So that earliest sign is rarefaction. All of you should make a note of it. Could be asked in the PG Met. So periosteum may be elevated. All of you can see here that there is some elevation of the periosteum here, and collection of fluid underneath, a subperiosteal abscess. And if it is 2 to 3 weeks, if you give some more time, then the abscess maybe into the soft tissues. All of you can see there is something wrong with the soft tissues here, and there is a new bone formation as it is. So bone is going into overdrive and start to create new bone as well. That means more than 2 weeks have elapsed to have all these changes. Initially, the organisms have to go and colonize in the metaphysis, and from there they spread in the medullary cavity, or they may form a subperiosteal abscess, and from there they can come out and make an abscess. And after that, in the breach, then once the periosteum is injured or there is a break, then bone starts building a new bone, which is seen like a new bone formation like this. So for all these changes to come, it will take some time. So never ever wait till these radiological changes. It's a orthopedic emergency, acute osteomyelitis. The moment you see the patient in casualty, you should be able to diagnose, and with the help of some maybe blood test which you can get within an hour, you can see increase in PNML and other things, then definitely you should start treatment. And if it is available and if it is the regular protocol in your center, then you can go for MRI, and you can see the pus spreading from the metaphysis through the medullary cavity into the diaphysis. See, from here you can see from one end it's going up. This is a pus, and if you want to clearly see in infections, you can do a bone scan with technetium 99. So all of you should remember this substance. Technetium 99 is used for bone scans in case of infection. So somebody says infection bone scan, even in your sleep you should say 99. What is that 99? It is technetium 99. So this is very, very important, and the uptake will be, that is very useful. Apart from other substances, if they may give you a list of 4 or 5 radioactive substances which can be injected and a bone scan is taken, but this is the one which gives uniformly good results, because there will be increased uptake in the areas infected areas. So this becomes a very, very good investigation, wherein the changes are much more earlier than in an X-ray. So X-ray you need to wait for 2 weeks, but here maybe within a week you can get. So if the symptoms are not clear, or you have a suspicion that it could be something else, then you can go in for a bone scan with technetium 99, or you can have an MRI wherein you can see the medullary spread. If you want to have a confirmation, then you can aspirate the pus in the bone. That you can do, and it should always be done under anesthesia. As it is, patient is very apprehensive because of the pain and all, and if you want to poke with a needle in the painful area, I don't think he will take it, and he will be take it kindly, even the parents. So you can do it under general anesthesia, and you should know the area of maximum tenderness. From there only the yield will be more. So it may not be more than say a few cc. So don't expect that there will be liters and liters of pus inside. No. So it will be few cc. So if you don't hit the correct spot, then you may have something called a dry tap. Okay. So to maximize your yield, you should know the area of maximum tenderness. Then only your yield will be good, and you can have pus. You can get a result for all your efforts. So you admitted the patient, you administered anesthesia, and if you don't get the pus, then you feel bad. So to do that, you should locate it even before you tap it. Then IND of the abscess, if it is subcutaneous or in the muscle plane, if it is there, then you have to do incision and drainage. So whenever you find pus anywhere in the body. This is also one of the footnotes in Bailey L. Love textbook of gen surgery. Whenever there is a pus, drain it. That is his dictum in gen surgery, the surgical principle. So whenever you don't leave it, once you leave it, the pus somewhere loculated or something, then it has a tendency to go around. So we don't allow that. We don't allow the infection to spread. So you localize it and you drain it, I and D. And whenever you do this, whenever you locate and drain it, then send it for culture and sensitivity. Then you know the particular organism which is the cause of this infection and the antibiotic for which it is sensitive. Then your treatment can be perfect. Coming to differential diagnosis. So whenever you are thinking of one diagnosis, you should always have similar conditions and you should rule them out to arrive at a correct diagnosis. So acute poliomyelitis. Acute poliomyelitis also, patient will have some fever and some GI symptoms, and there may be some paralysis. That is a true paralysis where the muscles are paralyzed. So you should not acute poliomyelitis and acute osteomyelitis should not be confused with one another. So in acute poliomyelitis, if you put your knife or something like that, you will be aggravating the condition. So never ever touch a patient of acute poliomyelitis. So you should be able to diagnose that muscle weakness is per se there or that is because of the pain. Usually this is only for theoretical purposes, but I have never seen a acute osteomyelitis being confused with acute poliomyelitis, for the simple reason that I have never seen a case of acute poliomyelitis. Coming to other differential diagnosis, scurvy is also painful and near the joints because of the their hemorrhages will be there. Subperiosteal hemorrhages in scurvy, very common. And septic arthritis, you can confuse one with the other. And septic arthritis, you should be relieve the joint from the scourge of infection. That means in septic arthritis, you need to operate as early as possible. You should drain the joint. So in acute osteomyelitis, it may not be imperative for you to operate as early as possible. So you need to make the distinction very clear between septic arthritis and acute osteomyelitis. They are very confusing. They are related, but in the joint, if it is there, that is septic arthritis. If it is not there in the joint, if it is there only in the bone, that is acute osteomyelitis. So if you know that, I think the confusion will be a bit less. And acute green stick fracture, very, very uncommon. If the fracture patient sustains some injury and it's a green stick fracture, all of you know that green stick fracture is very common in children, in that it's not a complete fracture, because a green twig will not break, it will bend. Similarly, a thick periosteum which protects the young bones, that is in children, will not break easily rather than they bend. There will be plastic deformation. So acute green stick fracture can also be confused with acute osteomyelitis. So these are some of the things which all of you should know, at least for writing theory. So once a patient comes to you, then with all your knowledge, the moment you see, you should be able to have a high degree of suspicion that this could be acute osteomyelitis. The patient has a severe pain, is not allowing you to touch that particular part, and has a swinging temperature, and is crying and is toxic, then definitely it could be acute osteomyelitis. And treatment has to start from now. And it should be aggressive. That means there is no antibiotic syrup you give after 6 hours, something like that. No, it should be intravenous antibiotics. And the child should be brought as early as possible. That means if within 48 hours, if the child is brought, that means the infection is still localized to the metaphysis. Then you should always hospitalize, and limb immobilization, because it's very, very painful. So if he moves the limb, being a kid, he cannot stay at one place. So he has to move, and when he moves the limb which is involved, it will cause a lot of pain and he will start crying. So to reduce that pain and crying, limb immobilization and sometimes maybe limb elevation. So this also will relieve the pain, the throbbing pain, because of all of you must have experienced at one time or other the throbbing pain of an abscess. So it could be a dental abscess or something. So it is very throbbing. Unless that pus is drained, you will not be relieved of the throbbing pain. Then IV antibiotics. So as soon as the patient comes, you don't know what is the organism which is growing, and after you take out the blood culture or you take the pus from the bone under anesthesia, then start, before that also you should start IV broad spectrum antibiotics. So the cephalosporins are the in vogue now. Some IV preparation has to be given, and it should be given for 4 weeks. Usually, even for surgery and all, even for joint replacements, we do give IV antibiotics maybe for 3 days or 4 days. But here you need to give it for 4 weeks. That shows the importance of eradicating acute osteomyelitis. Even after giving IV for 4 weeks, you are not sure that you have eradicated all the organisms. So IV antibiotics for a longer duration, usually for osteomyelitis. And usually we go in for IV antibiotics only, and if the patient's response is very good, then you can continue it for another 2 weeks or 3 weeks, depending upon the, by then you have got the report of the organism which is there and the sensitivity of the antibiotics. If the organism is not severe, it's a common organism, maybe you can watch all the while. You need to watch the patient's response, but IV antibiotics should be given for weeks together in case of acute osteomyelitis. And of course, some analgesics to reduce the pain and some antipyretics then to reduce the fever. If the patient is not responding to the above treatment, or he presents late to you, then you need to resort to what is known as a surgical treatment. Here what happens, instead of being in the metaphysis, it has migrated into the medullary cavity, and it has formed a subperiosteal abscess. Subperiosteal abscess, because the periosteum is very thick, unless it pierces the periosteum, it cannot come out. So before doing that, patient will have a very severe pain. And if you find the patient in this state, then you need to do what is known as drill holes. See, in this X-ray, you can see on the right side diagram, you have multiple black dot-like things and pointed out red by red arrows. They are all drill holes being drilled into the bone to relieve the pain. Once you do that, then the periosteum is broken and the bone cortex, and you go into the medullary cavity. Once you do this multiple drill holes, then the pus which is accumulated and which is there under pressure inside the medullary cavity can be easily brought out. Once that comes out, then the pain becomes very, very low or less, and the fever becomes very low, and the patient will become symptomatically all right. Then you send that pus for culture and sensitivity. If the patient comes to you after 48 hours, or if the patient is not responding, that means already there is a intramedullary spread, and the systemic antibiotics coming and curing will take a lot of time. So meanwhile, the organisms, if they are virulent, will go on the offensive, and on the left side you can see the periosteum is elevated, and unless you make drill holes in that area as well and drain the pus, the patient will not become normal. So this is one of the surgeries in acute osteomyelitis, only drill holes, acute osteomyelitis. Chronic osteomyelitis, there are several surgical procedures, but for acute osteomyelitis, multiple drill holes under anesthesia. Never forget that. So if you don't treat the patient, or the patient comes to you late, what are the possible complications? So because there will be bacteremia infection, it may lead to septicemia, and sometimes it may be a fatal conditions. And it will lead to chronic osteomyelitis, or it may lead to septic arthritis. And once the bone is prone for this infection and all, bone becomes weak. As we have seen, rarefaction, that means loss of its strength, loss of strength in the bone may lead to pathological fracture. And if from the metaphysis, if it burrows into the epiphysis through the growth plate, then even the growth plate may get affected, then there will be growth disturbances. So usually in severe infections, the stunting of the growth will be there, but sometimes in subacute infections the growth is increased surprisingly. So the limb on the affected side may be longer than the other side. So you should not be happy that at least this is long, because there will be what is known as a limb length discrepancy, which will lead to lot of complications. So both the limbs should be more or less equal for all of us to have a normal gait and with minimum problem. So these are some of the complications of acute osteomyelitis. There is another term called secondary osteomyelitis. What is a secondary osteomyelitis? The one which we have studied till now was acute osteomyelitis or acute primary, that may be because of the hematogeny. But here there is a wound infection as an open fracture or after operation. So as I told you, if you are not careful before, during and after surgery, you may infect the operated site and may lead to osteomyelitis. That is spoken to as a secondary type of osteomyelitis. You have introduced, that is because surgeons found. So that becomes our medical negligence. Iatrogenic, okay, but that word has to be not to be used according to our seniors in the profession. They say iatrogenic. Once you say iatrogenic, then the courts will think that you have done something wrong. So it is better not to use that word, iatrogenic. Sometimes if there is a wound infection, it will infect the bone underneath. So soft tissue infections, if they are not treated properly, may lead to bony infections, that is secondary osteomyelitis. And here, because it is secondary to something else, the constitutional symptoms may not be, the fever may not be so high and the pain may not be so severe. But you should be able to identify and do the needful. So it's a preventable condition, as we have already seen. So you should be very, very careful. Just because you have a patient and you know how to operate, don't jump at the chance to have knife in the hand. To have the knife in the hand, you need to qualify. First, you need to read up, know everything about it, and be confident about treating the complications, then only put the knife. See, that's the classical teaching. And you should prepare the part, especially in orthopedics, you should prepare the part. It's not like a general surgery or a cesarean section where the classical joke was children were playing marbles inside and then the doctor suddenly comes, no, please get out. We have a surgery now, and just put a table, get the patient inside and operate. That will never do for orthopedics. Okay, so you should have to have a sterile orthopedic theater, and people also should follow the sterility up to the maximum level. Even then infection can occur. Coming to the other important entity, this is chronic osteomyelitis. Chronic osteomyelitis, as we have seen, it's a persistent, the infection which has occurred, the unwelcome guest has become a part of our household member. He has become household member against our wishes, because our immunity is low. That means you are not able to say no vehemently. Then definitely they become unwelcome guests. Here in the diagram you can clearly see that the healthy bone is the lower end of the femur, and the upper end tibia, this is infection, metaphysis started, then definitely it went down the medullary cavity, and after some time If it stays for more than 6 weeks, then it is spoken to as chronic osteomyelitis. The characteristic features here in osteomyelitis is collection of pus in the medullary cavity, and there is a new bone formation. There are cavities in the medullary. These are all dead ones. So, and dying bone marrow, decreased medullary cavity, because this is active new bone formation on either side. So even the medullary cavity becomes very, very narrow. So this is one of the clinical x-rays. So this is a diagrammatic representation, upper and tibia, and this is the x-ray. Clearly you can see bone marrow cavity. This is a new bone formation which is clearly seen here. So coming to the etiology, acute becomes chronic. Why? Because you have not treated. That means the treatment was not started early, or the correct antibiotic was not given, or not given for proper length of time. And once it is an abscess formed, you didn't drain it, the drilling of the pus and all. So once the patient is not getting better, even with your IV antibiotics, immobilization and hospitalization, you should have gone for surgical procedure. But because you have not gone for surgical procedure, the acute infection has become a chronic one. And because you are not drained the pus adequately, then it started manipulating inside the medullary cavity, and a lot of changes of chronic osteomyelitis were seen here. And there is a presence of foreign body. So the dead bone becomes a foreign body here. So here you can see a cavity all around, and this is being a piece of dead bone. So the dead bone is known as a sequestrum, and all around you have a cavity filled with pus. And usually this occurs when there is a decreased host resistance. There are several causes for decreased host resistance, and drug lining, or if you don't take care of yourself, all those things will lead to decreased host resistance. The pathology here, you can find a sequestrum when that bone is cut off all around and vascularity is gone. Then this is a cavity all around, and this is a sequestrum. And sequestrum appears dense in an X-ray. So that is a common misconception, that the dead bone, because it is dead, it should not be visible. No. On the contrary, it becomes very, very conspicuous in an X-ray. We will see that. So this is a sequestrum which is taken out, and it has, how do you know that this is a sequestrum? It could be a normal bony piece. So whenever we take out sequestrum, then we test both the surfaces, because one surface which is in contact with the granulation tissue is very, very rough, and the other surface is very, very smooth. So outer surface is smooth. The inner surface, which is in contact with the pus and granulation tissue, is very rough. So if a piece of bone has a smooth surface on one side and a rough surface on the other side, then definitely, and it has some openings, then it comes out through the opening in the sinus, then definitely this is a sequestrum. And in the X-ray, you can clearly see that this part of the bone is quite sclerotic when compared with the normal bone. So the elevated periosteum, here you can all see, this is the periosteum which is elevated, and it forms a new bone formation. And this is a response from the body. So the new bone which is formed is known as involucrum. So there are some names here, all of you should remember. So sequestrum, involucrum. Involucrum is the new bone, sequestrum is the dead bone. And what are the clinical findings? A chronic discharging sinus in a bone somewhere. Then you say this is chronic osteomyelitis. Once you take an X-ray, in the X-ray, if you find a sequestrum, if you find periosteal elevation, if you find a new bone formation, that is involucrum, then definitely your diagnosis is confirmed chronic osteomyelitis. And sometimes the discharging sinus, you may see bone pieces coming out. So the dead and devitalized tissue, that is the bone, and body has nothing to do with it. So body wants to throw them out. So in the process of throwing them out, it keeps the sinus persistent. That's why even after 1 year or 2 years after acute infection, you may find the sinus persisting, and as and when the host resistance is coming down, then infection flares up and it starts pushing these bone pieces out. So that's a way of natural toilet, nature taking care of itself. Then because of all this infection all around, there will be thickened and irregular bones, and there is tenderness of the palpation, and if it is near the joints, then definitely there will be stiffness, because all of you know that this acute osteomyelitis is very common at the ends of the long bones, that is lower end femur and upper end tibia. So that is quite near to the knee joint. So in this acute osteomyelitis, if it turns into chronic osteomyelitis, naturally there will be stiffness of the knee. So clinical condition, sometimes it may be diagnosed after patient has a pathological fracture. Pathological fracture is a fracture which occurs in an abnormal bone. What is the abnormality here? The bone which is infected, that is a bone which is undergoing chronic osteomyelitic changes, can break easily with trivial trauma. So these are all findings of chronic osteomyelitis. And if there is a flare up, that means patient is suddenly having temperature, severe pain in a known chronic osteomyelitis, then that is called an acute flare up on chronic osteomyelitis, that is acute on chronic. And X-ray features, most of you know that the thickened irregular cortices, you can see here both the cortices. This is humerus, of course. So this cortex and this cortex thickened, and sclerosis of the bone is there, and sometimes sequestra may be seen inside sequestra, and involucrum and cloaca means holes being in the new bone, that is called cloaca. And pathological fracture if present, that indicates, and sometimes వచ్చారా sir? Yeah. So these are some of the X-ray features of chronic osteomyelitis, and the other things we'll take up in the next class. Thank you very much.